but also what those other things mean. So the Medical Board of Australia has also given us a little bit of additional complexity in how those hours are to be captured and what needs to be required. So educational activities, those more traditional things that you're used to doing. So attending tonight's webinar, for instance, is an educational activity. Telecare will be uploading your one educational hour on behalf if it goes for an hour, and that will accumulate up for that 12.5 hours. Reviewing performance and measuring outcomes, you need to do a minimum of 5 hours in each of those, adding up to 25 hours totally between the two. And measuring outcomes might be a clinical audit that you do, it might be a quality improvement activity that you do. Those can be both as a practice individually, lots of different ways, and we have a significant number of resources online for you all. So you've got your 12.5 hours education, you've got your 25, a mixture of reviewing performance and measuring outcomes. And then there's an extra 12.5 hours that you need to collect, and that can be in any of those three that make up the 50 hours. Now, if we connect that all together from an RACGP perspective, we will be capturing things that you do if you work for and with the college. So if you're in assessment, doing examinations in any way, case writing, if you're a medical educator, if you're a supervisor, those types of activities we will capture on your behalf and they will be uploaded for you. If you attend one of the college's education events or do an activity in our GP learning, if you attend like tonight, any one of our, I think over 500 education providers like Telecare, they will upload that on your behalf as well. And then obviously you can log practice or group activities, and I'll show you quickly how to do that tonight. And you'll also be able to quick log those other things that you do. So it might be a podcast, it might be reading a journal, those can be quick logged as well. So that's a bit of how you connect it all together. As a college, what we've also done, you can see down the bottom here, there's that hybrid. We have also, obviously, some activities can be more than one of those CPD activity types. So for instance, a practice meeting might be education and reviewing performance. So it depends what you're doing to how that is mapped. We have lots and lots of guidelines on our website. To give you an idea of what someone's CPD in a year might look like, this particular GP, and we have lots of different types of examples of this, you can see that they've done their PDP. This person's done it in an hour, it can be up to 5 hours. They might have done a MIDI audit that has 5 hours of reviewing performance and 5 hours of measuring outcomes. They've had 10 hours worth of practice meetings. They've done some online check modules in our GP learning. They might have done some reading and some reviewing performance alongside of that and talking to some colleagues. They might have some case-based discussions, attended some webinars. And you can see here how that's made up the minimum. We've got a minimum of 5 hours in measuring outcomes, and we've added up to 51. So it can look really different depending on what your scope of practice is, what you do in your practice, where you work as well. But we do have lots of different solutions and packages for you that you'll be able to see as well. Just to let you know, we've just launched the app on the App Store and also on Google Play. There is a CPD app that is available for download for free now. I think we've had over 10,000 downloads to date. It's been getting some really good feedback. It is a really simple way to capture that CPD that you're doing day to day, to see where your totals are at, what your statement is, and also to look and find for courses. So you can look and find, for instance, again, Telecare's courses that they're running in webinars and all of our other providers as well. The app looks a little bit like this. You can see it's a bit hard on this screen depending on where you are, but you can see that you can browse functions, you can log, you can see your history, and you can see where you're up to as well. And now what I'll do is I'm going to show you a little bit different format, what it is when you log into our website. So it is brand new. We have done lots of updates to it to simplify it for you. There is lots of resources there as well. So when you log in to RACGP website, it's called My CPD Home. You can see here up the top, you've got 20 hours. This particular GP has 20 hours total. They've met one of their 4 requirements so far. The RACGP requirement is that CPR that I talked about. You can see here, and I'll scroll through it. This person's got 8 out of the 12.5 hours minimum requirements under educational activities. They've met overarchingly 12 out of the 25 hours for reviewing performance and measuring outcomes. And you can see if you just dig down a little bit further, we've got a green tick against reviewing performance is completed. And we've got 4 out of 5 hours of measuring outcomes for this particular person, and then 0 out of that additional 12.5 hours. We can see here the professional development plan is completed. This is an example only. We would expect it to be completed at the end of the year. And then that RACGP requirement is CPR, and you can download your CPD statement as well. So just to give you an example of our PDP, and this is all it is online. It's hard in a screenshot, so I've just done some side sections here to show you what your current situation is. So we're wanting to know from you your current situation, so and the sample responses, just to see where you work. Are you a metropolitan GP? Are you a rural remote GP? Are you a locum? What your learning goals are for the 12 months for this particular annual cycle, your reflection on culturally safe practice, your annual reflection, and the time spent. And this is capped at 5 hours, and it comes under reviewing performance. So go in, have a look. You can save it as draft, you can edit it, and it's a really simple professional development plan that has been developed for GPs by GPs. The next section, our website, if you can see that we've got a browse section, and this is on the app as well, that you can search by particular topic. You can search by RACGP activities, you can search by provider activities, by reviewing performance, measuring outcomes, educational activities, blended by the date, by the location, online, all the different options that you might want to do. You can absolutely search by those. And some of those as well, you'll be able to register through our system as well, which is a new feature. And then if we move on, we've gone my CPD, we've gone browse, we're now at log. I'm not going to go through all of these with you, but if you click on the log at the top, what comes down is quick log. So that's where you're logging those things that you're doing in practice every day. You can log your CPR here. You can log advanced life support, any specific requirements that you might have for credentialing, and also those GP-led activities such as practice meetings, peer group learning, audits, lots of those. Even if you've got a evidence-based medical journal club, you can capture that there, and you can actually upload on behalf of other GPs as well. So there's some really handy things there. We have lots of other solutions for you and resources as well. This is just a side shot of all the other resources that we have. So we've got events, guides and templates, our journals, our clinical guidelines, our curriculum. All of those there are for you to enable you to assist you to understand what your CPD requirements are to complete your CPD. One of the things, actually two of the things you can find, there are two documents. One is called Activities for Your Continuing Professional Development, and one is called RACGP Solutions. Now, they are two documents that will show you what to do in terms of your scope of practice, which is your solutions, and all of the different activities and the evidence required, and the templates are linked into those activities as well. So there is lots there if you have any questions as well. So feel free to have a look. You will also find a link there to your local state faculty's RACGP office if you have any questions or concerns in your local state. So there's one in Victoria, but you can also contact the national office as well. And just a final slide, just to let you know, so we want you to visit the website, feel like you can download the app if you'd like to. Sort of January to March, we want you to start to log your CPD. You'll start seeing things collected there and captured. Then March to October, complete and record all those things you're doing. All those providers will do that for you. And then in October and December, we're going to send you some friendly reminders to track your progress and complete your professional development plan and reflection, so that that's all finished off by the end of this year, because we are in that annual cycle now. So I'm sure Telecare will share these slides. If I can send them through. If you need to contact us, please do. But what I might do, Janice, is stop and see if anyone has any questions. It was just a bit of this is the things that we're doing, this is what the program is, and that we're here to help. So
that is fabulous, Sharon. Thank you. So I am a GP myself, and I have to say, guys, everyone all download the RACGP CPD app. I think it's one of the best made apps from RACGP, and I think it's so easy for you to log in your CPD events. So thank you, RACGP.
No worries at all. I might just look at these questions if we've got just a minute, Janice. All right, how do I log my work as a practice surveyor with, okay, so we're working with our standards committee at the moment, who are working with all those groups that do practice accreditation, and there will be we've used the word solutions. There will be, all of those groups will be uploading some hours on your behalf. We're just working out what that looks like, and we'll be communicating with those groups as well. So we can absolutely let you know once that's finalised. If you do over and above what we'll be capturing for you, you'll be able to quick log that, just like Jenna said, through the app or also online as well. So if you self-record an activity but the organizer also registers, okay. So what we would do is look out for the RACGP logos. If they are an organisation that is a provider, they'll have the logos and the hours. If for some reason there is a duplicate there, we do have a quality assurance system, but you can also go and delete your quick logs. So you can edit them and you can delete them on our dashboard and online on the app as well. So feel free to do that. Okay, the other one, I teach medical students for about 4 to 6 hours a day. Do we log the full duration when they are with us? Okay, so medical students, we are working actually with the universities at the moment for all of the GPs that work with medical students specifically through that university not portal but system, that they will be either capturing it for you or they'll be sending that through to us, and we're setting up a system to enable that to be captured too. If for some reason you speak to a university or that's not happening, contact us. We can contact your university, or you could quick log that, but I would suggest just touch base with them and ask, are they letting RACGP know what you're doing, or are they uploading on your behalf? We're doing the same for supervisors. If you're have supervising practice or a supervisor through RACGP, you'll get communication really soon around what hours will be uploaded for you.
Perfect. And Sharon, I have a question, one more question for you from myself.
No worries.
PIP-QI activities with the PHN.
Yep.
Can we count that towards things like measuring outcomes and reviewing
The answer to that is yes.
Yes. Excellent. Thank you so much, Sharon. So if anyone has any further questions, please let us know and we will pass them on to Sharon. Alternatively, you can contact the CPD office at the RACGP, and we will definitely share the slides around everyone. Thank you so much, Sharon.
No, it's my pleasure. Thanks, everyone, and I hope the rest of the session goes well. Bye-bye.
Take care. Now, moving forward, it is my pleasure to welcome Dr. Shahid Haque, who will be providing us with a talk and demonstration on the examination of a newborn. Now, Dr. Shahid is a highly experienced pediatrician with extensive knowledge in all areas of general pediatrics. After completing his pediatric training and obtaining his fellowship in South Africa, he trained in pediatric cardiology and became a consultant pediatric cardiologist. Now, in 2006, he became a fellow of the Royal Australasian College of Physicians, the pediatric division, and worked as a senior pediatrician and head of the department in various states of Australia. Dr. Shahid can also consult with Telecare, where he provides telehealth pediatric consultations to all over Australia. So I am going to pass the floor on to Dr. Shahid now. Thank you, Dr. Shahid.
Speaker working on that. So Dr. Shahid, please speak on the microphone there. That's fine. Just speak towards the screen.
Yeah, okay. Can you hear me now?
Sure can. All good.
Yeah. Hello?
Yep, I can hear you, Dr. Shahid.
Okay. All right. Good evening and welcome to this session. Not a very good weather, that you're pretty good to come out. Right, I was given a task to just demonstrate, newborn examination. Now, most of the newborn exam is done in hospital after delivery, right? So in GP practice, I don't know how much you do, but the newborn examination doesn't stop there. They go home, they come back one reason or other reason, and sometimes the child health clinic nurse refer the baby to the GPs for various reasons. And obviously many mother goes to GP too. So the examination is not just one-off when the baby is born, it's actually ongoing. It's an ongoing issue. So what's the reason why we do the baby exam? We do the baby exam and repeatedly we do so that we don't miss out anything life-threatening, serious problem in the baby, even the mild, minor, whatever it is, we need to know. And there are many serious conditions. If we don't pick up, then baby can go home and sometimes they die, particularly with some cardiac problems. So that's the reason why we do the baby exam and we do repeatedly. So my first slide, I have a little bit of homework for you. It's just a brief short a case story. Can you show that? Next slide. Now, this is based on real case, okay? So this is 6 days old baby girl, and she was the firstborn to the parents. Normal delivery at term, and baby was well at birth with birth weight of 3.6 kilograms. Mom's pregnancy was uneventful, and she was not on any medications except the usual vitamins and whatever. Breastfeeding established with some difficulty on day 1, day 2. Baby vomited several times on day 2, but otherwise baby examined well, passed meconium. She went home on day 3, but came back to hospital on day 5 because vomiting after literally each feed with milk coming out of mouth and nose, but it is non-bilious. Before going home, similar type of vomiting happened a couple of times, but the midwives and the doctors examined and assured the mother. Okay, so this is, you can think about differential diagnosis. I'm not going to ask you now. You can tell me whatever you think later. Is that okay? You remember that? So it's all about vomiting. Days 5, day 6 old baby went home. So went home, came back, and vomiting. No diarrhea, no other issue. Breastfeeding, feeding, but vomiting, most of the feeds. Okay, next slide. So before we do real formal baby exam, we need some preparation for ourselves. Bit of a mindset, mind preparation, plus hand washing, hand hygiene. The one thing the babies always hate, that is cold hand and cold stethoscope and cold instruments. Babies will never give you an endless amount of time. They will remain quiet for a few minutes, and within that few minutes, we have to do most important examinations. Otherwise, you missed the opportunity. You have to come back next time to do the exams. So the cold hand, no, babies hate it. The environment has to be suitable for the baby because the babies, again, don't like the cold. So we don't expose the baby until we need to examine physically. While, let's say, if I'm doing a baby exam, I come, yes, I have washed my hand with warm water so that I'm sure my hands are not cold. And in hospital, usually everything is ready. There is overhead warmer, and or if I'm doing in the mother's room, there is also a heated room, good enough for the babies to be exposed. But before I even do the baby exam, I take a little bit of the history, the birth history, and the pregnancy history, because this is important. Important for the sake of the baby, mode of delivery, instrumental delivery, C-section, whether needed resuscitation or not. And was there any other issue? Was there any miscarriages in the past? And how the pregnancy was. And first thing is that before that, I introduced myself to mother. And I explained to her what I'm going to do. So I do a little bit of chit chat with the mother. So while I'm talking with the mother, actually, I say, look and listen. So I'm listening to the mother and talking to the mother, but I'm actually examining the baby at the same time. And almost 70 to 80% of the baby exam can be done just by looking and listening. Yes or no? Like this baby, while I'm listening, I'm looking at the baby. Okay, the baby looks quite small here, but let's say it's a good size, full-term baby. So baby may be appropriate for gestation, or maybe large, or maybe small for gestation, or premature baby, or IUGR. So all those things, I can see what is happening. I don't have to really touch the babies. And these are all these things important. I can see the baby's activities. Is the baby active, inactive, moving, not moving? See the skin color. Okay, so all those things I can do at the same time while I'm talking to mother, plus taking a little bit of time. Baby's activities is critically important to observe. Now, once we have done most of the things, then the examination starts from the head onward. So I have to leave this microphone now here. Let's see if we can do it. So expose the baby, and first thing, the baby exam is as easy as ABC. You just start on the head and finish the top. That's all. No system examination like adults, except there's one exception, and that is when the baby is quiet, you would like to listen to the heart first. Because if the baby is crying, you will miss the opportunity. And second thing you probably would like to do is to feel the femoral pulses as well. Because if the baby starts crying, you will have the real difficulty, because there's no point of listening to the heart if the baby is screaming. Okay, so that's the time we violate the rule. There's no rule here. Second thing is we learn to take the opportunity. It's okay. Thank you. We take the opportunity to every opportunity. Even the baby is crying does not mean we cannot examine the baby. We need a few things. That's the preparation, a stethoscope, an LED light, torch, a tape measure, maybe a time twister. So now, once we have done that, the first thing is that we examine the baby, and it's as simple. It's just the wrapping the head, your hand around the head. It's a small head, so one hand is enough, but I usually use the two hands, and I'll show you. Just like that. I sweep my fingers all around, and I feel the fontanelle. Okay, the fontanelle, I understand the size of the fontanelle. If fontanelle is bulged, is tense, or it is sunken, and his fontanelle is large or small. How many fontanelles we can see in a newborn baby? We can feel. Two? Well, there. Anterior and posterior. So anterior is just over here. We literally two parallel bones and the frontal bone joined together. And it's a diamond shape. Size is extremely big. Okay. So there's no standard size, but usually my thumb will fit in a normal term, full-term baby. Posterior fontanelle, well, you're lucky, you will feel it because it may be closed by the time the baby is born, full-term baby. But usually posterior fontanelle closes by 3 months of age. How long it takes for the anterior fontanelle to close? About 18 months. Great, good. So my purpose is that, okay, the head is a nice shape. There's no lumps or bumps or humps or anything. So that's good. And then I'm moving downwards. I look at the ears, and the ears are good. Looks normal. And then the right place, it can be anything. Can be low, can be abnormal, but this looks good. Then we look at the eyes. And this is another thing that we need to do when the baby is quiet, and that is the red reflex. You know, you need an ophthalmoscope to check the red reflex, but we can do that anytime. Baby will open eyes. You just have to have patience. So we'll come to that later. Nose, the patency of the nose, okay, and the nasal septum, if it is deviated, or sometimes nasal septum can be broken or fractured during the process of birth, not very unusual, uncommon things. The face looks okay, normal, symmetrical, there's no issues. The lips, the tongues. When we look at the mouth, we need the torch. Okay? We need good light to see inside. And it's better even to wear gloves and put your finger inside to feel that hard palate. Because if there's a cleft in the hard palate, only you will not be able to see that. So feeling the palate is a good idea. And then we're going down to see the neck. Now the babies don't have much of a neck, yeah? Because their head is on the shoulder, but still there may be something abnormal like a pyroglossal cyst or a cystic hygroma on the side. So we do need to see that. We look at the arms and both upper arms, the chest. Is there any increased work of breathing, intercostal recessions, or abnormal breathing, etc.? But also, while we examining the face and head, we listen. Is there any unusual sound coming out? For instance, very soft stridor. And if the baby's usually not on day 1, but day 2, day 3, but sometimes we may miss it in the hospital, but in GP practice, you may hear very soft stridor. What could that be due to?
Laryngomalacia.
Hey?
Laryngomalacia.
Yeah. Okay, laryngomalacia or tracheomalacia or both. It's not an uncommon thing. Most of them resolves on its own. Usually on day 1, we don't have it. But before they leave hospital, most of the time we know. Sometimes they might present a bit lighter or somebody has missed it. So that's very important. Now, inside mouth, as I said, the cleft palate can be missed sometimes if we don't look at it properly. Cleft lip, no, there is no cleft lip. And tongue tie, I'll show you some photographs and pictures later. So we down to the neck, the neck is fine, the upper limbs, that's fine, the chest is fine, and then listening to the heart. Now, since the baby is quiet, listening to the heart, and this is another time when you can't shut up anybody. Because when you are listening to the heart, then everybody will be talking. Whoever is around, they will start gossiping. The mom is asking questions, or the midwife, or the doctors, or junior doctors, everybody talking. You can't, you are wasting your time, because some of the murmurs that may be loud enough, you can hear even if everybody is screaming, but there may be murmur that's very soft, and you can only hear if it's absolutely quiet. An example, like if you get an ASD or a small muscular VSD, that is very difficult. It's very soft, and each of them are distinctly different kind of sound, and clinically can be diagnosed. VSD murmur is usually loud. Similarly, pulmonary stenosis murmur is loud. It's not good. Now, looking at the skin and the skin texture and the color. So what could be the color of the baby? It's usually pink. They're very pink because the hemoglobin is very high. They're polycythemic because, well, not polycythemic, relatively polycythemic because they live in relatively hypoxic environment in utero. So if not pink, what else could be? Other color? Purple? And cyanosis, there may be cyanosis, essential cyanosis. And that's only way you know if you look at the lips and tongue more importantly. Or maybe yellow, the baby jaundiced. And we need to know that because the baby cannot go home with the jaundice if the bilirubin is significantly high the next day come back. So the skin and chest, we have listened to the heart, we have listened to the lungs. One thing for sure, that if there is even a minute problem in the lungs, before you listen to the chest or the lungs, you will see how the chest is working. The recessions, depending on how bad it is. So from recessions to intercostal, subcostal recessions, suprasternal recession of tracheal tube to gland, everything can happen. But anyway, but still, we have to listen to the chest. Coming down the abdomen, baby's abdomen is slightly distended, more full. They're not like us, flat, no. Their abdomen is a little bit distended simply because their organs are large, because liver is big, everything is bigger. And then we palpate the abdomen, feel the liver, very difficult because the liver is so soft. But there's a technique, if you just be patient and gently go up, force the liver. Even if the baby is crying, that will not stop you from feeling the liver, because with the crying, the baby will breathe in and out, and abdomen will move up and down, and eventually you will feel the edge of the liver. The spleen is usually about a centimeter, can be about a centimeter below the costal margin because it's normal. If the liver is the largest organ, and the liver, spleen are the hematopoietic organs, not the bone marrow, it's taking over when the baby is born. Then looking at the umbilical, looking nice, clean, and healthy, that's fair enough. Now we have to expose the baby. Sure. And whatever you want to do. First, you want to examine the genitalia or the femoral pulses, it doesn't matter. Femoral pulses is extremely important, and we need patience. We need the right technique, and we have to put the fingers right on femoral pulses. And if the baby is not very happy, it'll be difficult. It's a bit of a challenging sometimes. But generally what I do, I just put my 2 thumbs on the femoral pulses. And even if until I feel, I go and sleep. I wait as long as it's necessary. If I cannot feel it, I come back and feel it. But it's easy to feel. Now, it's better to sometimes compare the femoral pulses with the brachial pulse. Why do we need to feel the femoral pulse? Why is it so important? Right question? Yeah, that's the only clinical sign of left ventricular outflow tract obstruction, mainly coarctation, and the femoral pulse is missing. Traditionally, textbook will teach you it is a radiofemoral delay, right? I think you all have read that when you're a student. But I think that's a bit misleading. Let's say this baby has coarctation and baby is in a sort of cardiac failure. Heart rate is 160 and 170. So each cardiac cycle will last for how long? 60 divided by 160, fraction of a second. Yeah, less than half a second. Can we appreciate that delay? No, there is no delay. Actually, the discrepancy. Either you don't feel it, or it's very, very feeble. Depends on how tight the coarctation is. So femoral pulse is critically important. Now, for the last, more than 20 years, a pulse oximeter has been introduced, but still many hospitals don't use it. Gradually, more and more hospitals are using them. So pulse oximetry in the lower limb will tell us if there is any issue. And that is not the substitute of feeling the femoral pulses. Right, we've done that. I'm happy. There's a femoral pulse. There's no problem. Now looking at the genitalia, the penis looks okay. You need to see the foreskin. And if there is any abnormality, never push the foreskin backward because it's glued and that causes injury to the patient. Now there may be lots of abnormalities over here, which I'll show you just very shortly. And then we need to feel if the testicles are down. So the best way is to just milk it down and then bring the testicle, the bottom of the scrotum, and then with your index finger and thumb.
You want to maybe turn the baby a little bit.
This way?
Yeah. So towards the camera again. So then everybody goes, oh, other way.
Yeah.
Perfect.
Okay. So the testicles are funny. They may be descended, well descended, but sometimes be sitting right up here. That's called retractile testicle. And I do see the fair number coming referred because no testicles felt or undescended testicles. They're there. So it's best is to just milk it down and then fill it. Nice. Okay. Other one. That's good. Fine, no problem. Then you need to look at if there is anything like hydrocele, which is not an uncommon. Hernia is unusual, but premature babies can have hernia. By the time you see, there may be hernia. So, and the genitalia there may be many different types of abnormalities in genitalia, right? So I'll show you some of them. Then the lower limbs, both the lower limbs, the feet, the number of toes, number of fingers. One thing I have already missed out, which you can do, we could do at the same time, or we can do like, what is that? Hip. So how do we do hip examination? Ortolani, yes, and Balo. So there's two tests. Now, I didn't find a fair number of referrals. They originate from the child health nurses or the midwives in the community, then goes to GP and send to us. Why? Uneven thigh creases. So what's the importance? What's the relevance of uneven thigh creases with a hip? What we call it the DDH, developmental dysplasia of the hip. So how does uneven thigh creases relate to the development of dysplasia of the hips? Any idea?
Maybe shortening
Shortening? Why?
the hips.
Exactly. So only time it will probably be uneven when one hip is dislocated, right? And the limb is short. That's why it's a short. Everything is, I think, textbook and is still teaching it that uneven thigh crease is equal to query DDH, but I don't find any scientific reason for it. How often our two sides of the body is exactly the same? No, very rare. If you look at everything and every organ or whatever, it's not necessarily. But yes, rarely. I think it's more incidental. Because hip dislocation at the same time uneven. Not many. I don't know if I have seen 50 uneven thigh creases querying DDH. I haven't found probably one. Yeah. So it's not really relevant, but we still have to do it. Now, when we do the hip examination, we need to think about what are the risk factors for DDH. Breach, yeah.
That's child, female.
Female,
Delivery.
sorry. Family history, yes, first degree family history. Yeah, heartbeat, neuromuscular disorder, spina bifida. These are all risk factors for the hip. So irrespective of whatever happens, we do the ultrasound most of the time. But all the breach, among the breaches, how many do we really see DDH? Very, very small number. I'm not always very keen to do the ultrasound, but the problem is that it's not only the dislocation of dislocatable hip, it's the relationship between the acetabulum and the head of the hip. Okay, and that we cannot always clinically detect. And DDH, developmental, it's a dynamic thing. It can happen later too. I'll tell you why. So how do we do ortolani and Balo? Can anyone do it? Okay. You do it. I think you know. I know. What does autonomy do and what does Barlow do?
Oh, there it is. But this will help. You're clicking there. Give me a positive chance.
Clicky is the positive.
Mhm. It's like what?
Okay, so which one does what? Barlow does what? And autonomy does what? Barlow actually trying to dislocate the hip that's dislocatable.
Yes.
And autonomy does the opposite. It's to relocate the hip that you have dislocated, now you relocating. So a little bit fine tuning. Technically, I can tell you, not many experienced pediatricians, even we have a neonatologist can't do it for me. So, yeah. I prefer to hold both the hips. Okay, the two things. The few things I do. First thing, what I do, I gently abduct the hips. Okay, and oh, sorry. So I abduct the the baby, newborn babies, everything is flexed, become flexed, and it's very hard to manipulate. So I just gently abduct as much as I can. A normal hip will go up to 180 degrees, literally. So if one hip is dislocated, one will go to the 180, other one will stop here. Okay, because there's a socket. The hip is the head of the femur is here, and it makes sense. And if that is the case, there is also a test that is just flexing the hips and holding like that on a firm surface. There's a hip, one hip is dislocated, that will be lower than the other one. Okay. Now, Barlow and Ortolani. So if I'm doing the Barlow, my goal is to dislocate the hip. If the hip is abnormal, it will dislocate, but very gentle. So the thumb is here, and my index finger is on the graded button. So I gently push outward and push downward and adapt. And then hip is dislocated, it will just slip. It will slip out. And autolining is just the opposite. Now the clicky hip is almost always normal. Its terminology is not clicky, it's plank. Click and plank is the difference. The click is usually happens because of friction between the ligaments. Okay, so the click is the wrong thing to say. It's a plank, which if you switch off any light or whatever switch, that sound that you get this plank. That is very important. Now, that's all about the hips. Then what we need to see is the anus. Okay, an anus is not just seeing superficially. We need to open it up and see. The anus can be in the wrong position. The anus may be missing, anorectal malformations and all sorts of things. And then once we have done that, we just want to see the back. The back of the baby, literally, you can put the baby on the tummy. Look at the spine, feel the spine down to the sacrum. And look for any abnormality. Spina bifida occulta. There may be clue, a tuft of hair, or there is some birthmark, some sort of things right in the midline that warrants a bit of a investigation, because that may give you a clue that there's something wrong with the spine. So from here, anywhere can happen. And if there is similar thing happening here, it's called encephalosis. Right.
Let's put up. No, there you go.
So what we do now? We done?
Reflexes.
Okay.
Reflexes. Reflexes.
Yeah. So first thing is that we do need to check the baby's tone, muscle power. Muscle power, we have seen how the baby moves, etc., etc. So how do we check tone? To gently lift the baby, keeping your hand, not touching it. The newborn baby can momentarily keep the head steady on the line and then will flop. But if the baby is floppy, the head will flop back. So that's one way to look at. The other thing you can do, hold the baby like this. As you see, the normal healthy term babies, everything is flexed. The elbow, the shoulder, the knee, somewhat like this. But the baby is floppy or hypertonic, everything is hanging. So that's a clue to the hypertonia.
Hi, Dr. Shahid. Do you mind showing that again, but in front of the camera for the people online, please? Thank you.
So this is about the tone. So first you can do, we just gently lift the baby with keeping hand here. And if the baby's tone is good, it will be, the head will be almost straight, horizontal for seconds, and then will flop. But if the baby is floppy, the head will be way back. So that's one way. Also, you will see that the baby's posture also will give you a clue. And then you're holding the baby like this. So normal baby with a good normal tone, the reflexed shoulder, elbow, the hip, the knees, they're like this. But if the baby is hypertonic or floppy, everything is hanging. Right. So that's more or less, in short, the tone. Then the reflexes. What are the common reflexes we look for? Okay. Hidden anything?
Cross.
Sucking reflex. Okay. One of the most important reflex is the moral reflex. Okay. How do we do moral? Moral, there are many ways you can do. Just gently lift the head with your hand under the head and let it go. This is the time you look at the mommy's eyes, okay? So be careful. And the complete good moral, the arm will go out and then will come. That's the moral reflex, complete moral reflex. Now, if there is a problem in one arm will go, other one will not go. And that can be due to brachial plexus helps mostly. Fracture. Even nowadays, we do find fractures, humerus fracture. I had horrendous humerus fracture of humerus, fracture of femur, everything, even not long ago. So that happens. So there's the motor reflex. Motor reflex is very, very important. Sucking reflex, that all baby sucks. You don't really need to put your finger to know that, but you can do that. Then rooting reflex. What is rooting reflex? Yeah, what we do is just gently touch the cheek and the baby will go that, provided the baby is in mood. If the mood is bad, don't do it. Or just fed, then don't do it. Also, rule of thumb is that don't examine the baby within half an hour of feeding, because don't maneuver and manipulation to give them a bit of the time. The rooting reflex is gently just touching the cheek and then looking over. There are many other reflexes, clavicular reflexes, stepping reflexes. That is, if you hold the baby like that, and the baby touches, baby's feet touches the surface of the bed or the table, they will assume taking steps. Okay? So the another technique is that just stimulating the dorsum and then the other limb will take steps. So there are many reflexes, but we don't need all of them. They're more for research than practical use. So this is more or less about, I think, the baby exam, and we found everything is okay, happy. Anything else you want to add or I missed out?
Spots and lesions. Skin lesions.
Yeah, that I'll show you now.
Dr.
that-
Shahid, there was a question online whether the Ortolani and Barlow maneuvers, whether they do hurt the baby.
When they, sorry, what the question was?
So whether the Ortolani maneuvers, whether they hurt the baby.
When,
Do they cause any discomfort to the baby to do?
the Ortolani and Barlow, whether it will cause
Correct. Sorry. Yes, that was the question.
No, that depends on the technique. One can fracture or damage the head of the femur. And that's the reason why the Ortolani and Barlow need to be trained. Now, I can tell you, if anyone is interested or a group of practice or any group together, there's a really wonderful video published by RACGP, a number of videos, how to do the Ortolani and Barlow. And it's not very expensive. You can buy it. I had one, but I didn't bring it because I used that for teaching in the past. So no, it won't do any harm because we take all precautions and we are very gentle. And that's the reason you can't do the Ortolani and Barlow when baby's screaming. Yeah, not letting you touch him or her. Any other issue? Any question? Anything that I left?
I guess the people online also wanted to know a bit more about the red eye reflex too. On maybe how to examine it and what to look out for.
Which one is that? Sorry.
The red eye reflex.
Oh yeah. That yeah. Okay. I have slides, but I will show you how to do that. I have a thermoscope in my bag. You do need a tape measure to measure the head circumference, but most of the time the midwife will do it. But you do need to measure, because if it goes to your private practice and you're not sure head is growing or not, or particularly if the fontanelle you think smaller, is the only way you can monitor head growth by measuring the head circumference. That's the pulse oximetry, but this one will not work for baby. Okay, so I just brought it for demonstration. You're lucky, it'll work, but it's not good. Okay, so it's critically important to check the red reflex of the eyes. Not only red reflex, actually when you're checking the eyes, you can look for lots of different things, or you find many other abnormalities that you didn't suspect. Like, you know, corneal opacity, coloboma, aniridia, that means iris is missing. Usually they go with the syndrome. Also, when probably forgot initially, when you're looking at the babies, just see if baby looks dysmorphic. Okay, subtle dysmorphism is critically important. So the red reflex, you can do many ways. The best way, if the baby is on mother's lap.
Mother?
Oh, that'd be good. And you are about just half a meter from the baby and looking to, baby has to open the eyes. Even if the baby is not opening, wait, baby will open the eyes sometime. And that you only get a second or two. They won't give you a lot of time. And then red reflex, what it looks like, I'll show you the photograph. Okay? Did you get your answer? This is the way to check the red reflex. Okay, so about half a meter from the baby. And you set it to 0. All right.
Dr. Shahid, one more question about the eye. We do apologize. We would love to know the correct method to do the eye cover test. Would you do that with newborns or more so infants?
Anytime, newborn, newborn, or even. Well, look, once the red reflex is documented and recorded, you don't need to do that again. But sometimes you may have, we also occasionally have difficulty to detect the red reflex. And then mom wants to go home. Then we ask the GP, if not, then come back. We do until we see the red reflex. We don't sleep. It's very important. So yeah, once it's recorded, it's not really important. But if you are interested, you want to make sure that the red reflexes are present, and the baby went to you at 4 weeks or 6 weeks of age, that'd be a good idea. Also for the practice.
Excellent. Thank you, Dr. Shahid. What about the eye cover test? Can you show us the correct method to do that on the baby?
Eyes.
The eye cover test.
Eye cover test. We don't do that on babies.
I thought so. Okay, thank you.
Eye cover test. Why do you think you do it? Can you tell me why you want to do it?
I think it's to check for a squint, I think.
Yes, to check quincy eyes.
Yes, but the newborn babies, we don't call it lazy eye. Up to about 6 months, we hang on to that because their eye don't coordinate. So that's why I'm saying, asking that question. So lazy eye, you can diagnose up to about 6 months. The first 6 months, very seldom newborn baby's eye will coordinate all the time. So that's eye patching, alternate patching, or sometimes they may need glasses. The best if an ophthalmologist see. Any other questions before I go to some of my pictures?
None online. Thank you so much.
Okay, all good. So the homework that I gave you, have you come up with an answer? Okay, fine. Okay. Right. So that's a lovely healthy baby. So if the baby is already undressed by mother or one reason changing that piece, it's an opportunity to see that the baby has a home. And what more you need, what you have done or what you don't know is the reflex, the heart, sound, and these are all possible. Especially if a baby like this, you more or less know everything. Okay, so that's the baby activity, that's the normal baby. And the baby, as I said, it can be big, large, etc., small, or whatever. Okay. That's the color, the central cyanosis. If you look at the mouth, you can appreciate the central cyanosis. What is this? Blue hand, blue feet. Okay. And this is central cyanosis is pathological. This is not pathological. So do anything to be distinct. And even when it's most of the time, it's when the baby is cold. If you go to sub-zero temperature and your hands exposure for some time, it will be like that. This baby is actually jaundiced. Okay, so when we examine the head, now we go into some of the abnormalities. Or when we say, okay, that baby was normal. What do you think is this? What is normal thing? it's a presenting from the edema of the skin. Yeah. So it's a pitting edema. So then that is camels. This is what, how do we distinguish between the two? Yeah, the capillohematoma never crosses the suture line. Why? Because the bleeding is subperiosteal. And the periosteum actually reflects downward underneath the skull of the suture. So it can't go here. But this is interesting also. Sometimes you, other will come to you and say, yeah, this baby still has swelling. 2 weeks later, what would you say? Tell the mother, I'm worried, I brought my baby and say, look, it's still got this swelling. It may take longer. It may take months, weeks or months. What are the complications of the capillohematoma? Possible complications, anemia because of the bleeding, depends on how much. Jaundice, it can contribute to the jaundice because there's blood will hemolyze. Funny thing happens sometimes, very interesting, is because this is blood and it will start calcifying. It will calcify, start calcifying around the periphery. Sometimes, maybe a month later, or 3 or 4 weeks later, you will feel it because its rim is calcified outside, the center is still soft. You may feel like this hole. Oh.
Hello, testing 1 2 1 2. Okay, So
Safe.
the of the camera, even the mics.
I think the mic's won't. Yes,
Hi,
and-
Sydney. I can hear you much clearly now.
Yes.
Can you do that test again?
Okay, testing 1, 2.
That is so much clearer. Thank you so much.
Yeah.
We might get you to go back to the cephalohematoma slide to talk and maybe start from there again if better. Lots of great comments coming in that we can hear you so much clearer.
Can we just
Yeah.
not use the mic and just be like this?
Yeah.
Okay, don't need, okay. All right, okay. So that's the layers of the scalp. And under each layer, what happens? So subgaleal hemorrhage is a killer because there is so much of space. I have seen one baby who's probably 1.5 volume of blood went into the head. Scalp. It's so dangerous. We needed 2 units of blood transfusion. And I had one hospital, I used to call it the world capital of subgaleal hemorrhage. Sorry.
What causes that?
It's usually birth trauma, but can happen spontaneously. And the trauma, when the depends on obstetricians, they use the QE or the suction. So they pull and the slips. They reapply. The pull, the slips. The more they do, more they cause this kind of problem. But occasionally it can happen spontaneously too. Why some of these babies die? Because it's a dire emergency. They need transfusion. They die because of DIC. So this is just to show the fontanelle, the anterior fontanelle, and there's a tiny little posterior fontanelle. This not necessarily always part of newborn exam, but by 4th week, the mother may come to you with head is a bit squashed on one side. So most of those are positional, posterior position of plagiocephaly. But it would be very difficult to distinguish between the positional plagiocephaly and unilateral lambdoids craniosynostosis like here. But there are tricks of traits that we can determine. You can see that if you draw 2 parallel lines this way, in plagiocephaly, the lines are parallel. But in lambdoid suture, synostosis, it is opposite. It's like this. And then there are a whole host of craniosynostosis can happen. This one is the mitotic suture. So the head looks a bit triangular. This is coronal suture, craniosynostosis. This is unilateral coronal suture. So their head shape looks odd. But this is something that we need to suspect and not wait too long. Okay, so that's a red reflex. So you will see exactly like this. Nice fleshy red. This one eye is got normal red reflex, another one is abnormal, whatever it could be. This one, the right one is normal, and the left one is most likely retinoblastoma. We can't miss it. This one is too small. And this is actually cataract on the right side. So with the reflex, the red reflex or the eye examination, what we can pick cataracts. retinoblastoma, vitreous hemorrhage, corneal scarring, retinal tear, retinopathy of prematurity, persistence of the tunica vasculosa, that's primitive something, we don't diagnose that. So cataract, retinoblastoma, these two things are not difficult to understand or to know. What's that? Hey? Anyone? Well, occasionally you will end up seeing a baby like this. Because hospital may miss it. Say anything. Facial palsy? No? How many think facial palsy? No one.
No, we got a couple here saying bells or facial palsy from online.
This one? This one is facial palsy. And this one is called asymmetric facial cry. It's the weakness of the depressor angularis muscle. And what's, you might say you're cheating. No. Facial palsy, look at the nasolabial fold, equals symmetric on both sides. And this is only the drooping that over here. Do you know any famous movie star who's got same problem? Sylvester Stallone. So this is true facial palsy. It may be instrumental, it may be spontaneous. Then we're looking at the mouth. What's that? You all know this, isn't it? Now, this is true tongue tie. The tongue tie that I see as referred to, most of them are not true tongue tie. True tongue tie. This is tongue tied. Look at the frenulum displaced to the almost tip of the tongue. And when the baby is trying to lift the tongue forms a V shape. That is something that you need to do something. So this is the anterior tongue tie. But there is also posterior tongue tie. That's more complicated. That means the muscle, the base of the tongue is sitting on the muscle, yeah? And that muscle may be displaced forward. You don't touch. This is easy. You can snip, anyone can do it. A dentist will charge $500, and the ENT specialist will charge $1,000. Most of the tongue tie, if not severe enough, it doesn't interfere with the feeding, sucking, or talking, or speaking, or anything. Okay, the question that, the case scenario that was given right at the beginning, any differential diagnosis of that?
Pyloric stenosis.
Pyloric stenosis on day 4 or day 5. How common is that? And it's not projectile vomiting. And it's also female. The pyloric stenosis is more common in boys than the girls. Anything else? Okay. Cleft where? That's what it is. And it is so easy to miss. And that's the case. That's a real case, not long ago in my hospital. where they examined everything, but they missed. The cleft was a bit smaller. That's why the milk is coming through the nose. Okay? And who diagnosed that? The mother. The mother was finally a student speech therapist. And she was not very happy. Anyway, so sort it out. So these are the things. So that's why the baby exam has to be done in good light and take time. If you haven't been able to see something, come back and see again. Sometime it may be missed from the hospital and then you'll be able to pick up. The skin, other than the color, texture, etc., what is this? It's a strawberry hemangioma, and it's in a very important area. How do we treat? Beta blocker. Beta blocker, yeah. That's another one. It's also in a very dangerous place because initially they tend to grow. The first few weeks, it keep on growing. Then majority will stabilize and then slowly regress. But here, you don't want to take that chance. You start treatment. That's a very small one, that's lip. So these are the areas where the hemangiomas we don't like, because there are some on pressure areas. When the baby starts sitting, that will cause problem. And I had one case, which was in the butter, and mom, after the first follow-up, disappeared, came back, and the baby started sitting, and the hemangioma is that big, ulcerated, bleeding, everything. Needed multiple laser. So this is hemangioma. Actually, it's lots of capillaries just in one place. There's another one. No worry about it. It's just the capillary hemangioma, port wine staining sort of things. They disappear slowly over time. What is this? It's called cutis marmorata. It's a benign condition. It just lasts for maybe the hours or a day or two and disappear. Just assurance. Don't send it to dermatologist. What's that? Café spot. So if any newborn baby in the first month have at least 3 café spot, you'll be very careful about it. Because café spot tends to grow with age in numbers and in size. And this case may end up being neurofibromatosis. Is there another one café spot as well? Have you seen anything like this? Half the body, one color, another half is another color. This is called Harlequin color chain. It's an autonomic vascular situation and nothing to worry about. You will see in half an hour, you come back, it disappears. Usually happen a couple of times and that's it. So it's not to worry about, nothing to worry. Erythema toxicum, very common, almost so common. You can see all over, tiny little dots, yellow in color, actually filled with the eosinophil, and you don't need to do anything about it. What do you call this one? Milia, already written there, milia, assurance. Chest, abdomen we've been through. What's that? Umbilical hernia. Mother is very worried. What would you do? I know it will come to us, Humby hernia, we do nothing. They close on its own because the recti muscles on both sides, as they grow, it'll actually close. If you're in Africa, every second kid, baby, even adult, you'll find them, and some of them are so big. That's about the femoral pulse we to look for and how to do it. That's the pulse oximetry. This is the right way of doing pulse oximetry, but if that one works, that's okay. Examination of the hips we've been through. So DDH. We have discussed the risk factors. So this is, the first one is a normal. The next one is subluxation. Third one is partially dislocated or low dislocation, and the last one is high dislocation.
When babies come and there's query DDH and decide to do an ultrasound, at what number of weeks do you do that? Because a lot of times sentinel and stop physiological immaturity repeat.
If the clinical exam hip is normal, but if still there is some reason to suspect there may be DDH, like the risk factors for breech, 6 weeks. 6 weeks of age. If premature baby, it has to be corrected 6 weeks, because if you do ultrasound on babies at 2 weeks of age, everybody has DDH because immaturity. Okay, so the acetabulum is shallow, not really round enough to hold the head of the femur. 6 weeks normally. But 6 weeks report, the radiologist will say there is mild DDH or mild acetabular rounding and ask for another one. Sometimes I don't do anything.
So would it then be better to just wait until it's 8 to 10 weeks old and then do one?
No, but if there is abnormality, significant abnormality, they need to be treated now. So this is just an X-ray, it's not important. So this is the Mr. Ottolini and Barlow. This is the treatment of the DDH. Doubling harness. But there are different types of harness too. That's not a dead body. Do you think this baby could have good reason to develop DDH? Even the baby did not have at birth. The answer is yes. Because the acetabulum cannot grow well because of the position. That's why swaddling is very a matter of concern, the way we tie the babies. In Africa, you hardly see babies with DDH, simply because within a few days of birth, most of the African mothers will take the baby on the back and go to work, and that itself sort out. Even if they have DDH, it will be corrected. I think this is a better way of swaddling rather than tying. Penis, testicle, as I said, must be, we must be sure that the testicles have descended. So if sometimes the testicles may have descended, but in the inguinal canal. So if it is in the inguinal canal, there is no rush, there is no worry, it still can descend. But if the testicle is in the tummy beyond 6 months, that testicle may not survive. What's that? Hydrocele. So transillumination and hydrocele will be clearly shown. But if it is hernia, you won't be able to transilluminate.
Excuse me,
Sorry.
last week I saw a 6-week-old baby has hydrocele. When you're going to refer or just to watch?
We don't normally do anything. Most of them will resolve, unless it is a very big, large, massive one. Now, hydrocele can be two types. One is just a closed hydrocele, the tunica vaginalis, that, you know, the canal that already closed, so fluid is now locked. Another one that is the communicating type. And when the baby lies down, the hydrocele disappears, but when the baby is up, then the fluid all comes back into the scrotum. They also can close, but there's no rush for it. Hydrocele is a benign thing. Most of the time resolves on its own. Very seldom they need surgical intervention. But if it is a hernia, that is urgent, unlike adults. Why? Because they risk for strangulation. You don't want that. Usually we see hernia more in prematures. What is this? Hypospadias, yes. And the hypospadias, if you're not careful, the urethral orifice may look like normal because there is a pit, but it can be down anywhere. So this is glandular, and this is the penile, and this is perineal. So anywhere the hole can be, urethra can end up anywhere. So if the baby's nappy is wet, does not mean a wing from the right place. Sorry, it's a bit small. This is ambiguous genitalia. This is a serious problem. It's called congenital adrenal hyperplasia. If undetected, they will die. Similar thing is a female, most likely, with virilized clit. Okay. Now, while you were examining the baby and open the nappy, you have done most of the things you have seen, you're happy, and lots of meconium in the nappy. Are you happy?
Days and just first day?
Yeah, shortly after birth. No, you still need to see the anus properly, exactly where, because the anorectal malformation. In a female, there may be rectovaginal fistula. The meconium will come out, but you don't know where you're coming from. So, and this is something time and time again missed, right? The abnormal, the anorectal malformations. Often it go with some sort of syndrome, Bartter syndrome or Bacter. This one, if you just look casually, you think that is fine. There is no problem. The anus is right there. But if you open up, you see there is a atresia. And if this one can go home, we'll have problem. So tone and reflexes I've already shown you. That's the moral. What's that? Erb's palsy. It's a birth injury. This one, difficult to say. It's got clunky. It's lower plexus injury. Herbs is a bit upper, and this is lower. So this will affect the hand. You won't be able to grasp. And if untreated, there will be eventually contracture and the wasting of the muscles, and the hand will be like this. Very rare to see nowadays. So these are the reflexes, the grasp reflex, plantar grasp, back and spine. Okay, this is the one that I said that there is a little bit of funny mark here. This may indicate the spina bifida occulta. This is just a sucking blister. Don't worry about anything. What is this? It's a newborn baby, day 1. What is happening? What is it showing? Edema. So why? Any clue? It's a tough one. Okay. Heart failure? No. You will never see edema in heart failure in babies and infants. No, infants. Very, very, very unlikely. I can give you another clue to that. Just got that. Waving of the neck. Turner syndrome. XO. So basically, if you see any baby on day 1, day 2 after birth with this, it's a non-pitting edema, right? Because it's a limp edema. It is Turner unless proven otherwise, provided that it's a female. And it's not uncommon. What's that? Okay, good. So that's what I was trying to say, that when you check, you can see all these things. It's a trisomy 21 on Down syndrome. It's this one. It's a Pierre-Robin syndrome. Sometimes it may have other problem too. So that's all I have to say. In short.
Thank you so much, Dr. Shahid. I just had a couple of questions from the online gang up here.
Yeah.
Maybe I might start with the first one. Adriana asked, if we did listen to a murmur on the cardiac exam, what should the next step to be? Do we need to refer to someone or keep an eye on it?
If any murmur heard in a newborn baby, the baby must be referred to a cardiac center or a cardiologist, or at least to a pediatrician. If the baby is not showing any sign of heart failure, or baby is not silenced.
It's because the slide.
Okay.
So just
Because as I said, even without murmur, baby may have serious heart problem. For instance, transposition of the great arteries without a VSD, there will be no murmur.
What if the baby looks fine, looks quite healthy, meeting all the milestones, growth percentile okay? Would you still refer to a pediatric cardiologist?
Yes, because we need diagnosis.
Correct. Okay, cool. Next question, Dr. Shahid. Now this was from Adriana again. She had a baby that had nystagmus, horizontal 1 to 2 beats occasionally on looking to the left to right. What would we do for that if the baby had nystagmus?
Nystagmus is not a normal thing. Nystagmus may be horizontal, it may be vertical. I would refer the baby to the ophthalmologist.
All right, thank you. a couple more, Dr. Shahid. Telepiece, when should you worry about it?
Which one?
Telepiece.
Talipes,
Mm,
right from the day one.
right on day one. Okay.
Yeah, so if there is a talipes, the talipes, okay, there are varieties of talipes. The club feet that we call is the BTEV, or if it is bilateral, talipes equino varus deformity. That is the most severe one. And you need to engage at least a physiotherapist immediately, because the feet are very soft and pliable and cannot be corrected. They need the splinting or even plaster, and sometimes need involvement of the orthopedic surgeon. But there is also what we call is the positional calipers, because one foot probably or both was against the equine wall, which is a very mild, which the physiotherapist can teach the mother how to manipulate and correct it. But yes, it's a club fit. Yes, they need to be referred ASAP.
Thank you, Dr. Shahid. We have a question from Irina about hemangiomas. Sorry. Now, do we initiate beta blockers or refer? And if we do initiate, what would the type of beta blockers be, topical, oral, or how much? Or is this something more like a dermatologist or pediatrician initiate?
I think it's best to not to initiate by GPs, at least pediatrician, because initially with the beta blocker, well, beta blocker originally used oral, now is topical as well. And needless to say, it works equally well. But if the beta blocker is given orally, the baby needs to be monitored very carefully, initially blood pressure, heart rate, and blood sugar.
Perfect. Thank you. Now we have another question from Shafquat. Now the anterior fontanelle, what is the earliest age the anterior fontanelle can close? And when should we be worried about it? Like, when do we worry about the anterior fontanelle closing too quickly?
Anterior fontanelle normally close by 18 months, but it can close anywhere between 6 to 8 months to 18 months. If the anterior fontanelle closes, then you need to monitor the head circumference. And if the head circumference is growing and not falling, I don't have to worry because the sutures are open. But it's better to check out by somebody like a pediatrician.
If we're concerned. Okay.
If it closes very early. Because
yeah.
I've seen referred because small fontanelle, 6 months, but that's okay. Head is growing. I'm monitoring the head circumference and I'm not worried about it. But it's not only the fontanelle, you need to check the head shape. So with craniosynostosis, the shape may look very funny, depends on which suture is closed. But yes, if it is closed very early, it's a matter of concern. But if the head circumference is growing along the line that was growing previously and not falling, then there is no rush, not to worry.
Thank you. In view of time, we might do one more question if that's okay. I know there were a couple of them coming through, but what we might do is we might gather the questions and then send it to you afterwards, Dr.
Yes,
Shahid, to see whether we can answer them afterwards.
Yes.
We might end with one more question, and this is an interesting one. Can we diagnose the type of jaundice a newborn has based on examination?
No.
Okay.
By default, we consider every jaundice is unconjugated. And why they have unconjugated, why do the babies have jaundice? And we call it normal, physiological jaundice. Jaundice is never normal. Is it normal? If I have jaundice, would you call it normal? No. But babies jaundice can be normal. And if it is unconjugated, because the multiple factors, because the baby's red cells survives 90 days as opposed to 120 days. So billions of red cells will die every day in babies, number one. Number two is that for the conjugation, the unconjugated bilirubin needs a chemical. It's called glucuronyl transferase. It's produced in the liver and it takes few days to kick in. So until the enzyme is sufficient, the body cannot excrete, because unconjugated bilirubin cannot go through the kidney or the gut, because it's fat soluble, and conjugated bilirubin is water soluble. However, if a baby who is jaundiced, no jaundice, it's unlikely the baby will be jaundiced on day one. If the day one jaundice, that's normal. But let's say day 3, 4 is a jaundice, but also baby has other features like liver is big and poo is pale, then yeah, that may be a serious problem, like biliary atresia. But generally speaking, we take it as granted, as physiological jaundice. And after 14 days, if we see the jaundice is not resolving, then we investigate. Some of them may have G6PD deficiency, but biliary atresia is very uncommon condition. Conjugated bilirubin, babies with conjugated bilirubin should not go under phototherapy per se. But most of the time, I think most doctors in hospital, when they check the bilirubin, send the sample to the pathology, they also ask for conjugated bilirubin. So that, but it's not necessary. The short answer is no. We consider that all bilirubin is unconjugated until unless proven otherwise.
Perfect. Thank you, Dr. Shahid. And on behalf of the online community here, we'd like to thank you for your fantastic talk on your examination of the newborn, as well as any abnormal findings. Before we get everyone, before everyone logs off, we still have the post-session survey to fill in. So what I might do is we might actually hear from our sponsors for tonight, which is uBroker. Thank you for sponsoring this talk tonight. And then I will put up the QR code for the post-session survey to get all those CPD points, and also a link on the chat as well. So thank you so much, Dr. Shahid, for your time.
Thank you. Thanks very much. And thank you all.
Thank you so much.
Yeah.
Would you like to go ahead sometime?
Just
Yeah.
no, to take that out.
The other person to oh, that's okay. I can change. She's going to speak. Our sponsor.
Hey.
Yes.
Oh yeah, sure. I mean, I just want to take it out, but I have to before.
No,
Yeah.
you can take it out.
Without.
Yeah. Without.
All right, I'll just get everyone to still stay on to fill up the survey and also to hear from our sponsors as well. It is imperative that you fill the survey up so that we can get those CPD points from RACGP. And For those listening online, here is the post-session survey to fill in those online and offline in person. Here is the post-session survey QR code as well to access it so that we can get you the CPD points from ACRM and from RACGP as well.
A quick introduction to who we are. We will be making a very short presentation today because I know the day has been long. We're really happy to be here today, sponsoring today's event. We're you brokers. My name is Charmaine, and we are essentially mortgage brokers and finance brokers. We have been in business in Melbourne for over 20 years, and over the years, we have written over $5 billion worth of loans, from residential, commercial to business, and even large development loans. The reason why I myself and also our principal founder of UBroker and Linda Tan is here today is because I want to tell everybody a little bit about the type of lending products and the privileges medicos are entitled to in the lending landscape. So we'll just give it a second until our presentation starts.
Is that okay?
Yeah, that's fine. So I just press downwards.
Just to press page down.
Okay. So in terms of today's presentation, we'll keep it nice and quick. Some of the main things we want to cover is something that's very topical today, and is whether bloody how are interest rates going, right? We've had 10 consecutive rises now. What's coming? But also, as Medico borrowers, who are you? How does the finance industry categorize you, and what type of benefits you're entitled to that ordinary borrowers aren't? But also some unique lending opportunities that banks are currently open to that are only accessible by medicos, and some of the streamlined assessments that are available for medicos. Okay. Sure how why we can't. Okay. I thought I'd chuck these graphs in because it looks remotely like a CT scan. I could be wrong. But the biggest culprit in the market at the moment, I guess, that drives the interest rate is probably inflation. You know, in 2020, when the pandemic first started, there was a widespread panic as to what's going to happen to, I guess, the economy. But little did we know, despite the lockdown, we've had significant amount of savings flying around in the economy. And hence on the left-hand side, you can see this is what we call the CPI indicator, which is largely the inflation indicator. And as you can see, it did bottom for the most part of 2020, but as everybody got used to the new norm, which is working from home, e-commerce and what have you, the economy didn't slow down. And as a result of that, prices of living, the cost of living started moving up. And along with that, the panic response against the central government is to quickly drop interest rate to facilitate the move on of the economy. What I want to put your attention to is the latter half of that red graph. And that's probably the sharpest increase that you can see since the early 90s for rate rise. Now, in the market, there's a lot of screams about interest rates going up. This is catastrophic. But when we actually look back at the market, interest rates are really just getting back to the same levels as most part of 2020. But the most probably important thing is where is the interest rate going right now? You know, when you have a look at the CPA indicator, despite the market rising, it is starting to peak down. And that's at the beginning of 2023. Since May last year, we've had 10 consecutive interest rate rises. And that's something I haven't seen in my lifetime. But I also have never seen 0.1% cash rate either. But the general consensus of the market, as you can see, is that the big four banks, which are what we call the market leaders, these are also the bank that gets the cheapest funding rates from the Reserve Bank as well. Everybody's of the view that maybe inflation is around about peaked and we should be able to stabilize. And by mid next year, inflation should start heading down towards the RBA's, the Reserve Bank's target of 3 to 2%. So hopefully by the end of this year or early parts of next year, we should start to see rates flatten out, or to the extent by next year, we should see rates coming off. So earlier today, I went to an industry event, and that's held by a company called Telecare Paediatrician. And these are valuers in the market. For those of you who doesn't know what valuers are, when you buy a property, after the contract of sale is signed, banks usually want to see a valuation and to ensure that your property is worth what you paid for. Now, the valuation companies' words are the most important ones our industry respect because it's a forward-leading indicator. A lot of the things that's happened in the interest rate and inflation market has caused two effects on the demand side as well as the supply side. Some interesting things we've learned. The demand side impact is actually quite interesting. We're expecting around 300,000 migrations to come into Australia this year, out of which 140,000, well, 30% of that is actually coming to Victoria, most of whom are coming to the metro areas. Student visa, I mean, the doors have just opened back up for overseas students to come back. And as of right now, there's 141 international student visa holders in the country. That's a huge number. That's certainly going to be a very interesting demand increase. But at the same time, there's also 15,000 apartments that's being constructed as we speak, and also further 9,500 that's in the planning pipelines. But that only works out to be around about 20 to 23,000 supplying, versus 141,000 visa holders alone, not to mention domestic demand. But also on the same side, we've also had a lot of supply side constraints from developers. Development costs are up. I'm not sure if any of you have been out there buying new property or off the plan property, but when you're driving around the city 2 years ago, you used to be able to see construction sites round up, whether it's big ones or small ones, everywhere you go. You don't see that very much anymore. Development costs are going up. Developers are holding back on developments, and those who are mid-construction are holding back on stock available to sell. So when you have an increase in repatriation of migrants and a delay in project and new house supply, you're going to have an even out of the market. So valuers, Telecare Paediatrician believes that land value should hold up, and this also includes house and land packages as well as apartment sites. Okay. This particular chart is interesting. I will make a note. The first line here, in terms of, that's Australian cash rate. That's not rate that's accessible to you. So when you walk into a bank, you're not going to be able to get your home loan down at 3.6%. This is the Reserve Bank's funding rate. You can see that as of June next year, the current book, by the way, this forecast comes from National Australia Bank, they're expecting the interest rate to have perhaps another 1 or 2 lifts between April and May, and then plateau for the most part of December before coming off the same time next year. At the same time, if you have a look at overseas competitors, our rates are still a little bit better than our major competitors such as the US fund rates, as well as our neighboring New Zealand. What I want you to have a look, focus on is the chart down below. This is the retail rate of the standard variable home loan on an 80% lend will cost you. This is around 1.6 to 2% above these rates. But at the same time, what you need to know is this is what ordinary borrowers can access. But as medicos, you also get a cheaper discount on commonly on rates like this. One of the important things I want to point out is this chart over here. There's a lot of doom and gloomers out there suggesting the property market is crashing, the opportunities are not there, hold your money, don't move. But what I really wanted to point out is the blue line here is interest charge. Interest charge has been going down as rates go down. But at the same time, over the last 2 years, the grey line has been increasing. This is voluntary repayment. People have been saving. Over the last couple of years, people have spent particularly more time, maybe because everyone's locked down at home and there's no one to spend the money, might as well make some extra repayments. Now, interest rates have increased despite 10 times from 0.1% now to 0.6. Overall payments relatively stay the same. It's still gone back to the pre-pandemic levels, despite voluntary payment has dropped. So, having said that, we know that the market's patchy. When you have strong migration and you've got an underdeveloped market, but as well as volatile interest rates, you've got this mismatch in terms of supply and demand. However, at the same time, if any of you have investment properties out there, you would have noticed that rents have increased on average 10 to 15%. Vacancy rates in Australia is sitting at under 0.1% at the moment. And auction clearance rates, big numbers, are still sitting at 60%. Sounds low, but it's actually 10% higher than the same time last year. What does that mean? Investment purchases in the market, as we know from today's talk, has dropped. The cost of holding an investment property is high because the interest rates have risen. But when we go to have the inspections and also auctions, we know that owner-occupied buyers are now coming into the market. Cash is still abundant in the market. And for those people, those market gap that has high income and high savings rates are really out there taking advantage of the average 8.7% drop in home prices. So let's have a look at lending products available to medical practitioners. There's a lot of names there I don't know how to pronounce, so I'm not going to try. But prior to the last couple of years, banks were already very, very welcoming to medical practitioners. This list has actually increased. In a difficult environment, lending environment today, banks are particularly aggressive in grabbing market share and good borrowers and people in the good earning industry, such as lawyers, accountants, professionals, as well as doctors. These are the categories. And what I want to point out is that what used to be classified as allied health in the lending market has now expanded to dentistry, veterinary science, as well as now pharmaceutical. I thought it was really interesting during my research for this presentation to find out exactly some funny little facts. And I realized that practitioners are all measured in the same way. So I don't know if that part is true, but I guess some of you can tell me afterwards. So what can medicals borrow? By the way, before I get onto this part, in the previous category, as medicos, you're entitled to make purchases in investment properties as in a personal manner, in a company structure, in a unit trust structure, in a partnership structure. But the most important thing is you must have more than 25% share ownership in any of the structures, and you are still able to be entitled to some of the benefits given to medicos. Now, these are some of the things that you can lend from. However, what I will reiterate is this does not apply to investment properties. You are only able to access these type of lending limits for owner-occupied investments. you are able to borrow 100% on commercial property. Whereas for a normal borrower, this can probably go from 70 to 75%. You're able to borrow 100% on unsecured business loans, including practice purchase, goodwill, working capital, and many other, and partnership buying. You're able to finance up to 100% on fit out and medical equipment, as well as vehicle financing as well. Now, there are different levels. For the most part, as an example, for unsecured lending in goodwill, you're able to borrow up to $2 million with something as simple as one BAS, that 1/4 of BAS statement, one ATO statement to show no debt, and a self-declare letter. No longer does the banks need 2 years worth of financials. Okay. If anybody has any questions in the meantime, please feel free to let me know. So then what are rates like these days? Interest varies. Obviously, the higher the risk scale, the lot higher the rate. Now, I will say that this is just a rough guide. Different banks have different rates. Some banks are more aggressive than others. Everyone's is trying to find a market share, but we do find in the market that some banks are much better, more friendly to commercial practice lending. Some are more friendly to residential lending, and others not so much. So for unsecured business loans, for example, goodwill, practice buy-in, partnership buy-in, working capital, and the rates can start from 7.5% to 8%, depending on the size of the loan and the nature of the loan. Fully secure loans, what are those? Equipment financing, okay, vehicles, fit outs that you want for your practice, and then also home loans. 5.24% for unoccupied and 5.69% for investment. And I will say, as medicos, on the home loan front, what I want to reiterate is the industry practice pre-pandemic has always limited you to 90% purchase borrowing without having to pay lender's mortgage insurance. However, in today's environment, you're able to borrow 95% without lender's mortgage insurance, most part. Commercial lending, principal interest payment for 15 years, offering up to 5 years in interest only. This is different from residential. If you were just to go out to buy a home or a commercial property that's under $2 million, you're most likely going to be able to get a 30-year loan, which is a lot easier to take down. You can get up to 30 years term with 10 years interest, but interest only on commercial property purchase refinance. In terms of fit out and equipment financing, the loan term could be 7 years, and the maximum loan term for vehicles is very standard, just like an ordinary consumer, up to 5. Outside of this, there are also a lot of great incentives for people in the allied health industry. And that in many banks, not just Tier 1 banks, but also Tier 2 banks are now starting to offer a lot of incentives. That covers ambulance, paramedics, other frontline professionals such as emergency services and defense force. And the biggest difference here is that not only can the ordinary base salary be calculated, but also shift workers, that's right. Yeah, that's okay. Shift workers, overtime, and bonuses also calculated and looked at within 100% assessment. So that wraps up the most part of our presentation. And just like your everyday health, make sure you have a look at your own home loan, because by mid this year, there will be around 800 fixed rate home loans that were scheduled into during the pandemic that will expire. I myself have had my super fund rates lifted because it came out of fixed rate term, and not knowingly, my rate went up to 8.89% on the super fund. And this is where I had to quickly go speak to my finance broker and quickly had a rate review and assess the increase based on the increase in the value of my own home property. I was able to reduce my rate from 8.8% to 6.5%. Because my property has gone up, lend earrings come down, and because I simply asked to get a rate discount. So if you don't ask, you wouldn't know. So again, I encourage everybody to have a think about and have a review of their home loan environment. If you have any questions, please feel free to come and speak to myself and Tana.
Perfect. And for the online people, once you fill in your form on the link, you are welcome to leave, and we will attempt to answer all the questions that we didn't get to answer this time round. Thank you so much for your time and have a fantastic night. Good night, everyone.
Thank you, Janice.
Our team and the university will be around a little bit. We will be on the phone more on the video.
Dr. Shahid.
You can save the form and save that URL to your notepad or somewhere, and you can finish and submit.